Good evening. My name is Roxanne Chabot from RBC Consultants. Welcome to another SkinChat webinar. This evening, we're going to review a consensus paper that was developed on promoting skin health and skin barrier health throughout life, so basically from cradle to grave, using ceramide-containing skincare. Our speakers this evening will be Dr. Andrew Alexis, who's Professor of Clinical Dermatology, Vice Chair for Diversity and Inclusion at Weill Cornell Medicine in New York. We also have Dr. Hilary Baldwin from the Acne Treatment and Research Center, Rutgers Robert Wood Johnson Medical Center, also in New York, and Dr. Lawrence Schachner, Professor and Chair Emeritus, Dr. Philip Frost, Department of Dermatology and Cutaneous Surgery, Professor, Department of Pediatrics at the University of Miami, Miller School of Medicine in Miami. We'd also like to thank our supporters, CeraVe, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you would like to submit a question to our faculty, please submit your questions in the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will be emailed to you within 1 to 2 days. We'd greatly appreciate it if you could fill it in and send it back to us. Within 1 to 2 days of the webinar, a certificate of attendance and the recording of this webinar will be emailed to you. Again, if you want to submit any questions to our faculty, please submit your questions using the question chat pane on the right-hand side of your screen. And I typed in a little note there so you could see where you need to type in your questions. So without further ado, I will pass the floor virtually to Dr. Schachner.
Good evening, all. It's a pleasure to be doing this webinar with my distinguished colleagues, Dr. Baldwin and Dr. Alexis. We're going to start out with a polling question. A lot of my talk will deal with barrier function in the atopic patient. So, what is the atopic march? We have 5 choices. I consider the atopic march one of the most important elements of approaching barrier function in infants and children whose parents and siblings have atopic dermatitis, because they are the high-risk children. So the majority of you shows the progression of early and severe atopic dermatitis issues, and that is correct. And we're going to talk about it in some recent literature that looks at that. Ms. Chabot,
yes,
talked about a cradle to grave consensus conference we had, looking at the use of ceramide-containing cleansers and moisturizers to improve the skin barrier. And the publication was actually just 2 months ago in Journal of Drugs and Dermatology, and basically 6 really experienced dermatologists covered skin barrier integrity in the newborn and infant, the role of the skin barrier in atopic dermatitis, but also looked at issues of skin of color, psoriasis, rosacea, and the xerosis associated with diabetes. We concluded the adjectives daily skincare throughout life will promote a healthy skin barrier, be beneficial in managing various inflammatory skin disorders, some which we'll review tonight. And we also created 6 statements. The 3 on the right deal more with adult issues. On the left, statement 1, that gentle skin cleansers, moisturizers, and applications of lipids can promote homeostasis of the permeability barrier. We want moisturizers that are near physiological in their pH, 4.5 to 6, pleasant to use, and ceramides and skincare regimens really do promote a healthy skin barrier. Our second statement, which we'll go over in more detail, compares the adult skin barrier, thicker and with a lower pH, and less susceptible to transepidermal water loss. Then we can conclude that gentle cleanses and topical application of physiologic lipids may promote homeostasis of the skin barrier. Statement 3, a defective skin barrier contributes to atopic dermatitis, pathogenesis, and chronicity. Now, moisturizers with ceramides can restore and preserve skin barrier integrity, improve clinical signs and symptoms of AD, corticosteroid sparing for infants and children, and can be used alone or as an adjunct to treat and prevent disease exacerbation, and some would say to markedly attenuate. So there have been 8 publications that came from this group who discussed the cradle to grave, 7 from the United States and 1 dermatologist also participated from Europe. Statement 2, so compared to the adult skin barrier, the barrier of infants and young children is thinner. It's actually 30% thinner and more subject to transepidermal water loss and issues pertaining to hydration. Moisturizers with humectants and ceramides can reduce the rates and flares of atopic dermatitis and decrease the need for topical steroid and other active agents that we use. Now, most importantly, lots of literature suggesting when started shortly after birth, skincare can attenuate or delay the development of atopic dermatitis and perhaps the atopic march. We'll look at it. We'll look at some science behind it. Gentle cleanses and topical applications of physiological lipids will promote homeostasis of the barrier, and we want moisturizers that are hypo, non-sensitizing, near physiological pH, and pleasant to use. So the skin barrier challenges in newborns and infants are profound because this 30% thinner stratum corneum still has to protect the whole body from toxins, from antigens, bacteria, viruses, irritants, all in our environment. But there's a lot of differences between infant and mature skin. We started with a group of derms, peds, and basic scientists in an article talking about the importance of ceramide skincare for normal and sensitive skin conditions in neonates and infants. And then we moved on to an algorithm. Now, the algorithm was aimed more at primary care doctors who provide pediatric care. But for all neonates and infants, we said that full body moisturizing after bathing and ceramide containing moisturizers preferentially will help with the barrier. We also advised the primary care doctors that when they have mild xerosis or scaling or erythema, that moisturizers are a very good starting point. If things exacerbate, of course, onto the dermatologist of choice who you'd refer to. Here is the scorecard. When we look at structural differences, babies compared to adults, a thinner stratum corneum, a thinner epidermis, less cell-to-cell adhesion, a flat DE junction, and less lipids. Now, all of them are going to allow increased permeability unless we support the barrier in various ways. And tonight we'll talk about CeraVe, the ceramide-based moisturizers and cleansers. The differences in infant skin also feature less melanin, less sweat, less moisturizing factor, a higher pH, and an immune system that lacks mature amount of defensins and cathelicidins, and the superficial microbiome having the same bacteria but in different percentages with a period of time needed for the commensal bacteria to develop. So here's a little interesting science done out of Asia where they looked at infants as compared to adults, and they found that the transepidermal water loss was significantly higher in infants, that the stratum corneum and epidermis was significantly thinner using confocal technology in babes than in adult skin, that skin surface activity for caseolytic, proteolytic activity much higher in infants. So you had increased desquamation, which would only lead to an even thinner stratum corneum. Research mainly in Europe, published in the British Journal, but also in the JID, looked at the maturation time it takes for an infant to thicken their skin to the adult level. And this work will show you that it took between 24 and 50 months for most of the infants to reach a stratum corneum thickness of an adult level. And it also takes a little bit of time for the skin surface, which we're born with a more alkaline pH because we've been swimming in brine-like amniotic fluid for the last few months. It's going to take a period of time, but it's awfully important that that acidification take place to form an acid mantle, old expression, but it's the acidity that defends against skin infection and can influence a positive composition of commensal bacteria. The process of skin acidification plays an important role in barrier maturation, but also in the activation of enzymes for the endogenous extracellular processing of stratum corneum lipids. So, higher pH, lower moisturizing factors, lower lipids, and a thinner stratum corneum, of course, are going to set us up for more water loss and hydration issues. So what do we have working for us if all those work against the baby? Well, the vernix caseosa, a lipid and cell-rich lining that covers the baby in the third trimester, covers the newborn. And if we leave it on after birth, as opposed to scrubbing the babies so they're pretty and pink the first moment they're born, if we allow it to separate over several hours to days, it's going to increase stratum corneum hydration, suppleness, and plasticity, but also help, at least transiently, decrease the skin surface pH, inhibiting pathological bacteria and facilitating normal microbiome commensal growth. Now, in newborns and infants with atopic dermatitis, appropriate moisturization in early infancy is an important issue for the daily management of the condition and maintains so, I would suggest to you, for a very long period of time. Now, 20 to 25% of all Western civilization and type infants and children are developing atopic dermatitis. Let's look at some of the factors that make moisturization with ceramides seem quite important. Here we're looking at non-lesional skin, and we see in green essential ceramides 1 and 3, among others, are decreased compared with healthy patients. And this is not on lesional skin. This is on non-lesional skin. So you can see even where there aren't lesions, the whole baby is at risk for barrier dysfunction. The vernix that we discussed is about 20% ceramides. With the mass maturation of post-stratum corneum skin, it has to get up to 40 to 50%. Now, what happens when it doesn't? You find a number of disorders in newborns as well as older folks really feature decreased ceramides, atopic dermatitis, xerosis, ichthyosis, and you'll see later on other disorders like acne and psoriasis. And that makes the babies more vulnerable to the atopic march. Excellent paper by Alan Irving described the atopic march as those early onset atopic babies who don't go on to have a healthy childhood, a healthy adolescence. Some do, but some don't. Some go on to have reactive airway disease with wheezing, sinusitis, rhinitis, polyposis in the nasal passage, as well as GI abnormalities. That, unfortunately, is the atopic march. And the younger the onset of atopic dermatitis, and the greater the degree of severity in early AD flares, the more likely you are to take this march. And if you have parents or siblings with atopic dermatitis, at the time you're born, you're much likely to go on to have atopic dermatitis and take the atopic march. But this is a really interesting study, some more science that looked at 1,900 babies of no description, just general population coming through a nursery, and they measured transepidermal water loss at 2 days and 6 months, and then looked at the babies for atopic dermatitis at 6 months with a score ad. Not surprisingly, about 19% of the kids had atopic dermatitis by 6 months. We said it's 20 to 25% in Western civilization. However, the researchers found that those kids who had increased transepidermal water loss at 2 days, statistically significantly, were going to go on and have clinical atopic dermatitis. In other words, we could tell at 2 days which kids were likely to go on and be atopic, and perhaps early intervention with liberal use of appropriate emollients might attenuate the atopic dermatitis, preventing atopic march. Our third statement from our consensus group said that effective skin barrier contributes to atopic dermatitis. Moisturizer with ceramides can restore and preserve skin barrier integrity, improve clinical signs and symptoms of atopic dermatitis, spare corticosteroid use, can be used alone as a monotherapy or as an adjunct in the more severe forms of atopic dermatitis. This disorder, because of its compromised epidermal barrier integrity, even in the intact skin, which isn't showing inflammation, shows us the need for gentle cleanses and moisturizers to promote a healthy skin barrier and to mitigate atopic dermatitis. Now, specific moisturizers have been developed, more sophisticated than the original paraffins and petrolatum, and they demonstrate improvement in skin barrier and reduced incidence of flares in clinical trials, both very desirable, clearly. The Europeans, in their consensus, actually recommended for adults a minimum amount of 250 grams, half a pound, of moisturizers be prescribed per week. That's, to me, a really amazing amount. And they said moisturizing bath oils and soap substitutes. We don't want soap. It has a pH of over 7. We want cleanses with a physiological pH of 4.5 to 6. Moisturizers with a higher lipid content were preferable, especially in cold, dry weather. And by using moisturizers, we can have a short-term and long-term steroid sparing. Even in the absence of disease, we've seen the chronic nature of atopic dermatitis requires ongoing basic care for the barrier and to prevent flares. Early daily use of emollients has been shown to reduce or delay the onset of atopic dermatitis, and the importance of their regular use should be highlighted to patients and caregivers alike. Now, starting around 2015, there were a number of studies, Eric Simpson, Hirakamaki, looking at atopic-prone kids, parents and siblings with atopic dermatitis, treating them by a couple of weeks of age and on, and they found attenuation compared to control groups of between 35 to 50% of kids did not actually have atopic dermatitis at the 8 to 12 month mark. Now, along the line, not every study has confirmed that. There was a period between 2019 and 2020 where a number of studies, including Chalmers, letter to the editor of Lancet, did not find similar results. But this group was using paraffin and petrolatum type emollients. And the author said, this does not appear confirmatory to the previous studies I cited, but the use of other emollient formulations might have a different effect, because he knew how basic the emollients he was using were. When I deep dived into this study, I also found that treatment was only once a day, which is far less than I would recommend, and probably you would recommend for atopics. And if parents were using the emollients as little as 3 times a week, that was acceptable to go into that database saying emollients weren't helping that much. So last year, the tide started to turn, and we saw this very interesting study, which published in the allergy literature, that showed that atopic dermatitis prone kids, high-risk kids, were treated by 4 days of age, which is what they did, and treated only for 2 months. And they picked that because they felt that's when the peak transepidermal water loss was. So we have high-risk kids treated for 2 months, examined at 12 months, 32% of the active treatment group with a ceramide-based emollient, as opposed to 46% in the control group, now showed atopic dermatitis. And that was almost a 33% decrease between the groups, statistically significant. If you look at this paper and look at 6 months, the delta is even bigger. A bigger group has still not emerged with atopic dermatitis at 6 months in a high-risk population where you would predict it. Conclusions: the study has demonstrated that early initiation of specialized ceramide-based emollients used until 2 months reduces the incidence of atopic dermatitis in the first year of life in high-risk infants. Well, that's good because we know if we can delay the onset and decrease the number of severe outbreaks, we can decrease the atopic march, according to Irvine's work. There is another paper that came out shortly thereafter that looked at 10 studies, and the studies, some pro, some con, but the authors concluded that the prophylactic application of emollients initiated in early infancy, the earlier the better, may prevent AD, especially in high-risk populations. And they recommended, as I do, continuous use. They hypothesized that that it would at least delay, if not prevent. And again, this was 10 different studies that they did an analysis of to come to that conclusion. Ceramide-containing formula moisturizers are of great benefit to our atopic patients. A growing body of evidence suggests skincare started early in life. We see as early as 4 days, recognizing the benefits of ongoing daily use of non-alkaline cleansers and moisturizers present a healthy skin barrier in all kids and are especially benefit in atopics, who when applied from a few days of age onward will help maintain the protective skin barrier that we want and improve xerosis, possibly delaying atopic dermatitis occurrence or mitigating the condition and decreasing the likelihood of an atopic march. With that, it's my pleasure to conclude that we want safe, healthy skin barrier promoting, fragrance and sensitizing free agents with benefits from lipids and water content in the stratum corneum that is so necessary for healthy barrier function, and products containing ceramides deliver this. And now I turn it over to my distinguished colleague, Dr. Baldwin.
Thank you very much, Dr. Schachner. I appreciate it. Sorry, hold on one second. Here we go. Okay. Last thing. All right. So I'd like to begin with the polling question. And it's a general one because I'm going to be talking about skincare in patients with rosacea. So do you buy the fact that rosacea is a primarily barrier deficient disorder? That's what I'm asking you. Because we have some indirect evidence, but we don't have the kind of ceramide evidence that Dr. Schachner was referring to with atopic dermatitis. In fact, we don't know what happens to ceramides in rosacea patients just yet. We know psoriasis, acne, and of course atopic dermatitis. So what do you think? Okay, I'm glad you're 50-50 actually, because that's how I feel about it too. I think this all comes down to a chicken and egg scenario, and I'm not sure which is the chicken and which is the egg. So, goodness gracious, sorry, hang on one second. Okay, very sensitive mouse. So a couple of us back in 2021, including Dr. Alexis, got together and talked about the evidence that there was that rosacea is a barrier deficiency disorder. And we talked about the importance, therefore, of integrating over-the-counter skincare products into our treatment regimens, rather than just sort of blatantly saying, yeah, go ahead and use moisturizers. And specifically, what did we mean by that? What did we hope to obtain by doing that? And then we got together again in 2022 and put it together in an algorithm. So we included medications and treatments for rosacea, as well as skincare recommendations. And we came out with an algorithm that looked like this, separating the patients into erythema, telangiectasias, and papules and pustules. We felt that papulopustular disease didn't warrant a specific algorithm for it. Talking about the medications down below that you can see that have evidence-based medicine behind them. But most importantly, we talked about foundational measures for rosacea in all patients. Behavioral measures, having them stay away from their triggers, for example, and sun and heat and cold as much as they could. But most importantly, good skin care and good UV protection with gentle cleansers, quality moisturizers, and good sunscreens that did not cause irritation. All during this, we kept in mind the belief now that we want to be talking about the phenotypic description of the patient sitting in front of us, as opposed to the old-fashioned subtypes, right? Papulopustular, erythematotele-telangiectatic. We can't squeeze a patient into one particular subgroup. So we now like to refer to it as the phenotypes. Do they have a little erythema, a little telangiectasias, a little ocular disease? And importantly, over on the right, this new phenotypic description of rosacea includes symptoms of itching and burning and stinging, as well as ocular symptoms. So you put together the whole picture of the patient, and then we can start to talk about quality skin care to back all of that up. So as you can see down in the bottom left, at least 6 different consent groups have all said the same thing. Let's get away from subtypes, let's talk about phenotypes, so that you have the disease entities, the characterization of the disease on the left, and then over on the right, we can talk about specific treatment for each one of those characterizations, noting, of course, that medications for persistent erythema don't make papules and pustules better, and vice versa. So if you have both papules and pustules and erythema, you need at least 2 drugs, or a drug and a treatment to get rid of it. And then addressing barrier repair early in the treatment phase and continuing it through the treatment itself and out to maintenance for the rest of your life is paramount in rosacea management. And then that all culminated in the article that Dr. Schachner referred to as before, and the rosacea section was statement 5. So I guess we're a little bit closer to the grave than we are to the cradle, showing the evidence that there was for rosacea being a barrier deficiency disorder, and again concluding the importance, therefore, of quality skin care. So what do we know about rosacea? We know that it's very common, probably 10% of the US population. It's said to be more common in Caucasian women from Northern Europe, but I practice in Brooklyn. If I waited around for somebody from Northern Europe, I'd be waiting a very long time. So this is likely due to reporting bias. And Dr. Alexis and others a couple of years ago published an article showing just how incorrect that was, that rosacea, although not as common in patients with skin of color as it is in lighter skinned individuals, is by no means rare. And we need to keep a high index of suspicion when we're dealing with patients with skin type 5 and 6, especially where the erythema might be more difficult to see. Rosacea clearly characterized by both inflammation and vasculopathy, and also, though, environmental factors that can interfere or help our rosacea patients. That improving the barrier reduces their symptoms, and the opposite, using skincare products that have, for example, a high pH, very detrimental in our rosacea patients. In this particular article here, they said that utilizing poor skincare generates a vicious cycle, causing a prolongation of flare-ups and a worsening of rosacea symptoms. Not only do we have to just sort of, again, blithely say, use skincare, we need to make specific recommendations based on our knowledge of quality skincare products. Dr. Tan published this article several years ago that showed that within the various rosacea subtypes, the symptoms and the signs of dry skin, for example, and plaques and burning and stinging are very different between the patients who are primarily vascular and those who primarily have papules and pustules. You can see, for example, that stinging and burning is actually more common in this study in papules and pustules than it is in vascular, that the dry skin appearance of vascular disease is more common than that of papulopustular. They went on to suggest that maybe it's an imbalance in the fatty acid concentration in the sebaceous papulopustular patient that influences skin barrier integrity. In this paper, they looked at the acute irritant threshold in atopic dermatitis and in rosacea. And I think they thought that they were going to find that although rosacea has a barrier dysfunction, that it was inherently different from atopic dermatitis. And actually what they found was that transepidermal water loss and skin hydration in both diseases was deficient. That transepidermal water loss was higher in atopic dermatitis than it was in rosacea, but both were worse than with healthy patients. That skin hydration was decreased equally in rosacea and atopic patients compared to control. And that the interesting thing was that the location of this barrier dysfunction was different in rosacea, limited to the rosacea-prone areas on the face, than it was in atopic dermatitis, where it might be lesional, but it also could be absolutely normal-looking skin on the forearms of the patient with atopic dermatitis. So here's a couple of graphs that showed what they found. On the left, we're looking at transepidermal water loss. On the right, we're looking at skin hydration by corneometry. Atopic dermatitis is in the black and rosacea is in the hash marks. Healthy skin in white. So on the left graph, you see the nasolabial fold on the left and the volar forearm on the right. So you can appreciate that in the nasolabial fold where rosacea is, that rosacea and atopic dermatitis had the higher bars, which represent more transepidermal water loss than normal skin. But on the volar forearm, only atopic skin was abnormal. Rosacea looked just like healthy. On the right, we're looking at skin hydration, even Steven between atopic dermatitis and rosacea, both less than healthy skin, but on the volar forearm, not the case. So clearly, rosacea skin is an increase in transepidermal water loss, a decrease in skin hydration, and our use of topical products to help this are going to help both the symptoms and the signs. So our patients with rosacea often complain of skin sensitivity, and although we have a hard time defining exactly what that is, patients seem to know what they mean by it. Patients with vascular disease often describe themselves as sensitive. They say, everything bothers me, even water. And if we look at the 5% lactic acid stinger test, which is a hallmark of patients with elevation is a hallmark of in patients with transepidermal water loss disorders, you see that 100% of patients with vascular and 68% of the patients in the study with rosacea had abnormal lactic acid stinger test. So clearly a barrier deficient disorder. Disruption of the stratum corneum barrier probably playing an integral part in the presence of these symptoms. Made worse, of course, by stuff that they put on their face. So these are two studies by Helen Torok on the right, Zoe Draelos on the, Helen Torok on the left, Zoe Draelos on the right, looking at things that patients were doing to their skin that was causing problems. Not surprisingly, astringents and toners at the top of the list, but also soaps. As Dr. Schachner mentioned, soaps are not all created equal. We want one with a nice low pH. But look at the other things on the list that include makeup, for example. And over on the right, Zoe tells us that sunscreens and pharmaceuticals are often a cause of skin irritation in our rosacea patients. This study is very hard to look at, so I'd rather you focus on the conclusion than the graph itself. This was a study looking at the incidence of rosacea in the Chinese population, and they found it was extremely high, especially ETR, the vascular form, which is in the blue, compared to papules and pustules in the pink and phyminous in the right. Now, I know you can't read what's down at the bottom. The important part about this study was that they found that the patients who were doing things to their skin were making their problem worse. They found that the development of rosacea was closely correlated with excessive use of facial cleansers, which means twice or more a day, the use of facial masks, which our patients love to use, makeup, which they like to use to cover up their redness, of course, and regular visits to beauty salons or to facialists, which made things 10 times worse. So without our guidance, patients are making themselves worse. Improper skin care has been shown to worsen both forms of the disease, and good skin care has been shown to result in an improvement of rosacea signs and symptoms, even without therapy. Good skin care also improves the tolerability of the medications we want them to use. Many of our patients, for example, have a hard time starting with 15% azelaic acid because it causes burning and stinging in about 25% of patients. In this study, they put on either Cetaphil or CeraVe moisturizing cream and then put on their azelaic acid, and both moisturizers greatly improved the ability of the patients to use the drug, that can help them to solve their problem. So for a moment, let's talk about skin pH because it's a crucial part of this. Skin pH, of course, plays an important role in barrier function. If it's abnormal, the enzymes within the stratum corneum aren't working well. Natural moisturizing factor is not being produced as well as it should be. Lipid processing is abnormal. The barrier breaks down, and this has been particularly well documented, as Dr. Schachner indicated, in atopic dermatitis, but also in rosacea. And we can actually normalize the pH of the skin with acidic skin preparations like cleansers and moisturizers. So we can actually make things better while teaching our patients how to cleanse and moisturize their skin. So we have to educate our patients, avoidance of triggers, gentle cleansers, making sure that the pH of their cleanser is nice and low. Now you can't just say, make sure your pH is low, because the bottles don't say what the pH is. So you need to make specific recommendations. Of course, avoid exfoliating, choose quality moisturizers, and of course, sunscreen as well. So our algorithm ended up looking like this, with a lot of the medications and the level of evidence over on the right. But the most important part of the article was talking about skin care and sun protection. Quality moisturizer, low pH cleansers used once a day, please. Why twice? Right? If you don't have greasy skin and you washed your face before you went to bed, why are you washing it in the morning? We suggest once a day maximum with a low pH cleanser that you've specifically recommended, followed by the use of a quality moisturizer. And of course, sun protection at all times for our patients. Education being the crucial part of rosacea care for our patients. And the bottom line is that no rosacea visit is finished until you've discussed in detail, specifically, good quality skin care. So the conclusion is that we have this algorithm now that combines both prescription medications and gentle cleansers and moisturizers for all of the rosacea phenotypes. And we address skin facial barrier repair early in the treatment phase, continuing it throughout the acute phase and on to maintenance and basically forever, which is paramount in rosacea management. Now it's my pleasure to introduce my friend and colleague, Dr. Andrew Alexis. Take it away, Andrew.
Well, thank you, Hillary. Appreciate your warm introduction, and what fantastic presentation so far by Dr. Schachner and Dr. Baldwin. It's my pleasure to be the third speaker here for tonight and cover some concepts with respect to skincare across diverse patient populations, including those with skin of color. So let's kick things off with a polling question. I'm just going to advance. There we go. Which of the following statements is true? Xerosis is less conspicuous in patients with skin of color. Pruritus is less prevalent in populations with skin of color. Black skin has lower ceramide content than white skin. Or inflammatory skin cannot be treated by over-the-counter moisturizers. Or physiologic pH is between 7 and 8. Please take a moment and fill that out as best as you can. Okay, very good. We've got a majority that actually picked the correct answer, which is that black skin has lower ceramide content than white skin, according to a couple of studies, which we'll talk about tonight. For the 44% that picked the physiologic pH, we'll also talk about what the actual physiologic pH is. So thank you for answering that. So when we think about the diverse spectrum of patients that we see in the US and around the world, we quickly recognize the diversity in all sorts of aspects of the skin, including potential variations in structure and function of the skin, variations in cultural skin and hair care practices, as well as variations across populations, but with respect to cultural norms as what is healthy skin, what is beauty. And all of these factors intersect to produce variations in what we see clinically in our office as far as the prevalence of skin diseases, as well as the quality of life impact of skin diseases, and even some nuances to treatment of skin disorders in patients belonging to a diverse range of backgrounds. When we look at our patients with skin of color, we see common disorders that can affect any population, but when they present in the background of richly pigmented skin types, there are some nuances in presentation and treatment, including the development of pigmentary alteration from inflammatory conditions like acne, but also the risk of inducing pigmentary alterations with therapies that we might prescribe or therapies that our patients may try themselves before they see us or without our recommendation. And so as an example like this, with acne and associated irritation from topical prescription products here, this is an example of where skincare recommendations are so important in terms of promoting a healthy barrier and reducing risk of irritation from our prescription products. Atopic dermatitis, we know that there are morphologic variations of atopic dermatitis when it presents in darker skin types, including a tendency towards follicular accentuation. Psoriasis is often under-recognized, underdiagnosed in patients with skin of color. And from the patient's perspective, they often see the scaling, the silvery scale, and interpret that as dry skin, and often turn to over-the-counter products for moisturization for quite some time before they end up seeing a dermatologist making the right diagnosis. Now, when it comes to over-the-counter agents, they really play a key role in so many aspects of managing dermatologic disorders. We see that patients themselves will seek out OTC agents first as a first step in many cases before they come to see us. And then once they do come to see us as dermatologists, we often have to then alter or make specific recommendations that are more in line with their condition and the prescriptions that we prescribe. We might select agents to enhance the tolerability of prescription agents that we prescribe, such as in the example of acne. We might use over-the-counter products, leverage them for maintenance phase and hoping to reduce the use of corticosteroids in atopic dermatitis, for example. And so clearly over-the-counter agents play an integral role in the management of dermatologic diseases. And we'll talk about some of the evidence for using sophisticated moisturizers in the management of a broad range of patients. So when asking ourselves, well, what is the evidence for using sophisticated moisturizers, including those that contain ceramides? You know, are all moisturizers the same? Does it really matter? Well, it turns out that there's quite a bit of published evidence showing the advantages of using carefully designed moisturizers that contain physiologic lipids like ceramides and other skin barrier promoting and protecting ingredients. And when we think about the broad range of diverse racial ethnic populations and skin types, are there any particular barrier differences that we need to keep in mind? The reality is, the short answer is that there's very limited research in terms of understanding differences between self-identified racial ethnic populations and barrier differences. And we recently reviewed what is published on the subject in this paper in 2021. But cutting right to the bottom line, as far as our review of the literature, we found that it was limited to small sample sizes in many of the studies, varying methodologies, sometimes conflicting data, and lack of clear definitions of the specific racial ethnic groups being studied, and lack of standardization of skincare regimens before certain measurements of stratum corneum structure and function were done. So these are some of the limitations. That being said, there have been some differences that have been reported in more than one study. So it's been replicated by at least one or more groups. And one such difference is ceramide content in the stratum corneum in black skin compared to other skin types, including this study from New York, from Long Island, diverse patient population, 3 self-identified populations, African American, Caucasian, and East Asian. And what was found is that the African American group had significantly fewer ceramides in the stratum corneum compared to Caucasians and East Asians in this particular population studied of over 300 patients. Another study outside the United States, this is from Copenhagen, Denmark, 3 groups, all residing in Copenhagen, self-identified ancestry from Africa versus East Asia versus European ancestry. Again, ceramide, in this case, ceramide to cholesterol ratio in African subjects was significantly lower than the comparators, Asian and Caucasian. So we wonder whether this contributes to the observation that cirrhosis is a particular burden among patients with skin of color. And if you add to that the conspicuous visual appearance of cirrhosis, of scaly skin in skin of color, and the burden that it places culturally on many populations with skin of color, especially those in the African diaspora, where having dry, ashy appearing skin is culturally stigmatizing and is sort of a faux pas. And so there are variations in one's cultural norms with respect to moisturization practices and selection of soaps and cleansers and tendency and preferences for fragrance, etc. There are also population differences in terms of itch, and some interesting work by Gil Josipovic and Sean Quatra and others have identified a higher prevalence of itch among African Americans, and there are a few thoughts as to why this might be. So with all of this background, let's talk about some basic concepts in skincare that can address some of the issues that relate to the barrier when we're treating patients across the whole range of ages and skin types and inflammatory diseases. So one concept is the importance of using cleansers and moisturizers that are close to the physiologic skin surface pH. So what is the physiologic skin surface pH? It's between 4 and 6. And it turns out if we use agents that are very basic, much higher pH, we could, this results in deleterious effects as far as the skin barrier, as was eloquently described by Dr. Schachtner earlier and by Dr. Baldwin. So when it comes to moisturizers and moisturizing ingredients, they are not all the same, and the different aspects of moisturizing ingredients. Some are considered occlusives. This means that they are substances that form a hydrophobic layer on the surface of the skin, preventing evaporative water loss from the skin surface. Examples of this would include petrolatum, dimethicone, and others. Then we have humectants, ingredients that are humectants. They attract water to the stratum corneum. Examples would be glycerin, urea, hyaluronic acid, and the others shown. And the most effective moisturizers combine both occlusive and humectant moisturizing ingredients. So we're drawing water up into the stratum corneum, and we're preventing it from being evaporated with this combination. The addition of physiologic lipids like cholesterol, ceramides, squalene, and others can enhance the effects of moisturizing creams. So what's the evidence for that last statement? If we add physiologic lipids to moisturizing creams, does it really have a clinical and barrier function benefit that can be proven? Well, I'm going to share with you a few published studies that help answer these questions. First, this is an investigator-blinded controlled clinical study of 49 women with dry to very dry skin. They were asked to use a ceramide-containing moisturizing cream twice daily on the lower leg. One leg got the treatment, the other leg remained untreated, so they acted as their own controls. And so let's see what happened. After 4 weeks of use of the ceramide-containing cream, there was an 11% increase in total ceramide content in those individuals. And this, even after 48 hours of discontinuation, there was still greater than baseline level of ceramide content in the skin. Let's look at other lipids. Increase in cholesterol levels and free fatty acid levels were also seen in the ceramide physiologic lipid containing moisturizing cream in this split leg study. Clinically, what did the patients look like? We see at the top row a sort of what's called an average clinical result in the study, and an above average exceptional result, exceptionally good result at the bottom. And you can see from baseline to week 4 improvements in the visual features of dryness. Now, what about using ceramide containing creams in conjunction with our prescription therapies for inflammatory conditions like atopic dermatitis? Well, in this study by Zoe Draelos, it was a 4-week study, 60 subjects with mild to moderate atopic dermatitis, randomized to 3 groups. One got fluocinolone cream plus a mild bar generic cleanser. Second group got the fluocinolone cream plus a ceramide containing hydrating cleanser. And the third group had the three-pronged approach of the steroid, ceramide containing hydrating cleanser, and ceramide containing moisturizing cream. And as one might anticipate, the group that had all 3, corticosteroid in conjunction with a ceramide containing hydrating cleanser and a ceramide containing moisturizing cream, performed better and had a statistically significantly greater rate of achieving clear for these subjects after 4 weeks. And so this helps give us some evidence for the utility of incorporating sophisticated moisturizers like this into our treatment regimen for our patients. Here's another study, this one comparing the ceramide containing moisturizing cream to a generic, simple paraffin-based emollient that's on the UK National Health Service formulary. Comparing these two with the blue line, the blue curve representing the ceramide containing cream, we see that ceramide lipid levels were increased, lipid concentration was increased significantly greater than the paraffin-based emollient cream. And you could see that with a number of tape strips, there was still a higher degree of ceramide containing cream, so going right through the layers of the stratum corneum. What about skin barrier function? The use of the ceramide containing cream compared to the generic paraffin cream produced a protective effect against transepidermal water loss increases after tape stripping. So improvements in skin barrier integrity, in other words. What about in response to irritants? In this study, subjects were exposed to a harsh irritant, SLS, sodium lauryl sulfate, as a patch applied for 24 hours at day 29 after using either the ceramide containing cream or the generic paraffin emollient. And we can see that redness was less in the ceramide containing cream, and so was increase in transepidermal water loss, in other words, showing that protective effect against an irritant as SLS. So in summary, what we've shown is that there is a great deal of evidence for the value of using ceramide containing creams as part of our overall approach to a number of skin concerns that we see, from xerosis to atopic dermatitis to others. And given that we're short of time, I'm going to stop right here and turn it over for questions. Thank you very much.
So again, if you want to submit some questions to our faculty, please submit your questions on the right-hand side of your screen. And if you think of any questions after this webinar, you can always send them to info@rbcconsultants.com. Again, we'd like to thank our supporters, CeraVe, for making this educational event possible. And also, please remember to join us for our next Skin Chat, which is Tuesday, May 30th at 7 p.m. on dermatology in the social media era, building awareness of social media's impact on adolescent skin diseases and mental health. So we'll go to questions now. We have a couple of questions from the audience. What characteristics of quality skincare products are most important in rosacea-prone patients?
Well, I guess that's my question. The most important is more the absence of problems than the presence, honestly. We want, as Andrew mentioned, we want a combination of a great emollient, something that's going to add softness and suppleness to the skin. We want an occlusive agent that's going to help to seal in the moisture of the skin, and we want a humectant to draw in moisture and to keep it in place. We don't want any fragrances. We don't want any irritants. We don't want any parabens. I mean, there's a whole list of things we don't want. And of course, we want to make sure that the pH is nice and low, somewhere between 4 and 6. So there's a lot of different products to choose from. I would love to be able to say that ceramides are the quintessential additive to moisturizers for rosacea. And I think they probably are, especially considering the data that Andrew just presented that show the lack of ceramides, for example, in darker skinned patients, and we know are rosacea prone as well. So, but we don't have that data yet. Until we do, I'm still convinced that ceramide containing moisturizers are the most helpful for my patients with rosacea and the least likely to be irritating. But I don't have the data to back up that statement.
Okay, another question. For acne patients, in what order do you recommend applying non-comedogenic moisturizers, before or after application of prescription medicine?
Andrew, you want to take that one?
Yeah, I'll be happy to take that, but then I will definitely want to hear your take on it, because I know you have an opinion. It's a great question, a very practical question that we face every day. Our patients might ask us, all right, so in what order, when do I put on the moisturizer? Do I put it on before or after the prescription agent? And some of us might be thinking that there may be benefits to applying it before the prescription agent, like a retinoid, where we might want to reduce the risk of irritation by applying it before. That being said, what do? I have the patient cleanse first, then put on the prescription cream, then moisturize after. In some circumstances, if the patient has very sensitive skin and is not able to tolerate that traditional method, I will reverse it and have them apply a ceramide containing cream prior to the application of a retinoid. And I have confidence in doing so because of a published study a few years ago that demonstrated that you could still maintain efficacy when you do it that way. What do you think, Dr. Baldwin?
I completely agree with everything you said, except I'm old-fashioned. Back in the day, we were told, specifically with tretinoin, not to put a retinoid on top of a freshly washed face. Do you remember that, Dr. Schachner? Specifically avoiding that. So I don't necessarily tell them to wash their face first. In fact, I would love for them to put their retinoid on top of a dirty face when they first get home from school, and then wash off the whole kit and caboodle before they go to sleep. Dr. Schachner, what do you think about that concept? Is that crazy, putting it on top of a dirty face?
Well, I don't have that on my prescription pad, but I understand entirely what you're saying. And yeah, that is old school, and I'm much older school than Dr. Baldwin, but that is how we've been doing it for the last 40, 50 years or so.
We have a question for Dr. Schachner. If you do not recommend soap, what do you recommend for cleansing in babies?
Okay, so soap by definition, and as Dr. Baldwin said, it doesn't always come in the wrapper, but soap by definition is alkaline. The pH is going to be 7 and above, and that's not desirable. So we don't want the word soap on whatever we're going to use to wash our healthy or atopic babies. There are any number of very good baby washes, and even ceramide containing baby washes that I would recommend. This is one time, don't look for the pH, but look for ceramides within the products and look for the absence of the word soap, and then you're off to a very good start on picking the right thing to cleanse your babies with.
We also have a question for Dr. Baldwin. How is the effect of Demodex in pathogenesis and morbidity of rosacea?
Well, how long do you have? And we could do a webinar on this. You know, we don't know. There are several studies that show that Demodex population is increased in patients with rosacea. In fact, increase in their area of rosacea and not right next door. So it certainly seems as if Demodex is playing a role. But we're back to the chicken and egg story, which just permeates through the entire skincare discussion when we're talking about atopic dermatitis and rosacea. Which came first? Is the follicle just so lovely that the Demodex want to live there so they multiply? or did Demodex cause the rosacea to begin with? And we just don't know cause and effect here. So I think we also know, of course, that topical ivermectin can make rosacea patients better. So I think Demodex does play a role. I'm just not sure whether it's causative or reactive. I think it behooves us to decrease the Demodex population if we can. And besides, they're kind of gross, aren't they? And see if that makes the skin improve. But I do think it plays a role, if not just triggering the innate immune system and causing it to behave erroneously.
Well, unfortunately, that's all the time that we have this evening. We'd like to thank you all for joining us, and we'd like to thank Dr. Alexis, Dr. Baldwin, and Dr. Schachner for a very comprehensive presentation on the skin barrier in various therapeutic areas and for patients of various ages. So thank you, and good night, everybody.
Good night.
Good night.
Good night.
Bye.